All right, welcome everyone. We'll wait a few seconds to give people some time to come in. Thank you everyone for being here. Welcome. All right, so today is a little bit of a different webinar for us. Today we are giving some information about our new medical coaching and consulting program and walking you through what that consists of so everybody can have an idea. So we'll start with the goal is to improve quality of life for patients with complex, multi-system chronic conditions. And let's see if my slide wants to move. Uh-oh. It does not. I'm gonna stop sharing and can somebody else try to share? Sorry about that, guys. We did test beforehand and technology just sometimes does what it's gonna do.
I can go ahead and share if you want.
Great, thank you, John. Perfect. Okay, so we can go to the next slide. And we're going to talk about, who we are, what the problem that we are seeing, the gaps, the challenges, give you a little bit more insight as to what exactly is medical coaching and consulting, what that scope of practice is, how we're approaching this and thinking about accessibility, and some examples of the work that we've done and next steps. Next slide, please. Okay, so starting with our disclaimer, our coaching services are not intended for diagnosis or treatment and do not establish a doctor-patient relationship. All information provided is for educational purposes only. Any changes to your health regimen should be made in consultation with your healthcare provider. Clients must have their own qualified licensed clinician for diagnosis and treatment adjustments. Next slide, please.
Oh, there we go.
All right, so a little bit about the team. I'm Isabel. I am a board certified health coach, and some of you guys know me with Renegade Research. I'm Renegade Research CEO and director for the Remission Biome Project. I am a systems engineer by trade with a lot of work in the pharmaceutical industry. Always been obsessed about research and improving quality of life for clients that I work with. I've had MECFS for 43 years, and I have been married for almost 32 years now. That needs a little bit of updating. I have 3 adult children, and for fun, I like to garden, forage, and do fun homesteading projects around the house. And if this is your first time with us, I usually introduce Renegade Research. We're a nonprofit 501c3 organization, and we are dedicated to research that's agile. And we also have been doing clinical education and now the coaching and practical advocacy. So if this is your first time with us, also welcome. And John, if you can introduce yourself, please.
Sure. Hi, I'm John Houghton. I'm the Chief Medical Officer for Renegade Research and have my clinical training is in rehab physiatry, and I have an engineering background and a clinical focus on long COVID and MECFS and longevity, and a lot of systems experience with population health and digital health. From a patient journey perspective, I had long COVID from 2020 to 2022. Now resolved, and bone cancer that was cured by the NIH back when I was a teenager, and still end up with some secondary effects that really remarkably overlap with some of what we see in us and long COVID. Married, 3 daughters and a dog.
Cat.
So that brings it to me. So I used to teach science communication at University of California, Riverside. Previous to that, I have a background in history and in animal science. My publications are in history of genetics and history of nutrition. You may have seen some of my work on glutamate on Twitter. That's been a strong interest since being in the pilot study for Remission Biome a couple of years ago. And I suppose I should add, I am also married with 3 dogs and 6 cats.
And we call her the glutamate boss. All things glutamate.
Every time I get a remission, we get a pet.
Tara.
Hi, everyone. I'm Tara Fody. I work with Renegade Research as a research director and also was a participant in Remission Biome. I hope to use that experience as well as my experience in public health and healthcare, where I worked in patient-provider rapport and communications and also in improving healthcare systems, and my experience with MECFS and chronic Lyme disease to help with operations and scheduling and work as a peer navigator.
And Tara is uniquely positioned, being also on the research side, being able to, work on that intersection with us. I mean, we all work in both ends, but it's great to have another person that can easily navigate between both worlds. All right, next slide. So I assume the majority of you on here, know what the problem is, if you're a patient or if you're a clinician or a researcher. So I'll go through these things a little bit as fast as I possibly can. We're looking at complex multi-system chronic conditions. Many of them, the trigger is an infection, and we have the label of infection-associated chronic conditions as well. 2 prominent conditions are MECFS and Long COVID, but they're not the only ones that fit this category, right? So for MECFS, an estimated 15 to 30 million patients, and about 50% of those patients with long COVID meet the criteria for MECFS. And as you guys all know, there are no approved treatments in the US for MECFS or long COVID. And there are co-infections, there are comorbidities, situation is complex. And to top it all off, we also have very limited expert clinicians that can, navigate the complexity, and patients have access to those clinicians. So next slide, please. So MECFS, if you're not familiar, is a multi-system neuroimmune illness. It's characterized by debilitating fatigue that's worsened by activity, and this is called post-exertional malaise. That activity does not have to be physical activity. It's characterized also by unrefreshed sleep and disturbances, cognitive difficulties, overlap with autoimmune conditions, and the challenges that patients face are around diagnostic, treatments, resources, disability, etc. And there's been, decades with limited research and treatment options. And then 2020, we had the pandemic, and, long COVID happened shortly after. So the post-acute sequelae of COVID, there is a long list of reported symptoms that include PEM. And again, about 50% of those patients are considered to meet the criteria for MECFS. Not every long COVID case is also MECFS. There are different presentations. We have over 65 million patients worldwide as of 2023. And the prevalence seems to be between 5 and 30%, with a higher incidence in those that have been hospitalized. We see it in children and adults. And there is a higher risk in both conditions, actually, of developing autoimmune conditions as well. Next slide, please. Okay, so the statistics, the projections rather, look very grim, right? If things continue the way they are, we are looking at over 1 billion people worldwide by 2033 with long COVID. That's a merely 8 years away, and that goes by in a flash. So this is why, action is needed, and it's needed now. So every hands on deck is what we need to do to try to change this projection. Next slide, please.
And as we go to the next slide, I think everybody's aware, but the risk of getting long COVID in these post-infections is cumulative. So the more times you get infected with the acute virus, the more likely you get some residual effects later.
Great point. Okay, so what are the gaps? The gaps are that, of course, there are no approved treatments. Specialty clinics are closing. We had a good number of clinics open to treat long COVID, but they are closing, either a lot of them for lack of funding. And there are long wait times for those that are still open, or for specialists who were, very understanding and proficient in treating MECFS before COVID. And for those that are not closing, a lot of the times there are geographical limitations, and there's also, financial restrictions for access. So again, the wait is long, and many are not accessible because of severity, financial, or geographic factors. And without any treatments, the quality of life continue to decrease. And for many patients, unfortunately, that is, it takes a deep dive and plummets. So we are merging the available research with what we have experienced, coaching participants in Remission Biome Project and our private clients, and the education materials that we have developed in collaboration with the available science and research, and putting it all together to try to scale and meet that gap so that patients can have the help that they need to be able to communicate and help their providers help them. Next slide, please. Okay, so for patients, managing a chronic illness is more than just lifestyle and supplements. Sometimes you'll hear, the word coaching, and the initial assumption is that, that's a person that it's gonna, tell you to eat better and, lose weight or whatever the case may be. And there is just so much more to coaching than that. Coaching can help you understand the symptoms and put it in the context of your entire presentation, what the needs are, and help you progress to effectively communicate with your healthcare providers, with your healthcare team. We can help you with what is the emergent research and how is that applicable to the entirety of the condition, but to you with your unique picture. How that is, applicable at the individual level, how to discuss those set of factors with your healthcare providers and move your treatment forward in a targeted manner. And practically speaking, what that looks like is interpreting results, exploring potential causes of adverse reactions to medication, supplements, based on your biochemistry, identifying early warning signs of disruption that can lead to PAM, and how to manage that so it doesn't get to that point, and identify promising biochemical pathways that you can focus on, and again, in conjunction with your provider, drive treatment. Next slide. So based on the current state and evaluating your individual picture, so some of the things that we can do together, and this is not an exhaustive list, is, identifying when it may be a good time for you to test for tick-borne illnesses and co-infections, helping you identify when is a good time to pursue diagnosis for mechanical issues based on your presentation. What are the genetic factors that the literature say are influencing the whole presentation of this condition, and how does that apply to you? What are the factors in your microbiome? What are the foundational lifestyle factors that do apply to you? And we are happy to involve your practitioners and your caregivers in the entire process. So it is a team effort. So we also look at not just these factors that I mentioned already, but how can we help based on all of the aspects, right, that are affecting the way that you can proceed. So your financial access, not everybody is going to be able to have access to the same tests, whether because of finances or because of, they're not available where you are. And how do we help you move forward with alternatives, with, putting things together in a way that in the absence of this factor, we can help you still craft that framework and help you work with your provider. Practical support, right? How to work with social support and the caregiver landscape, the heterogeneity of the condition and the individual responses. And we look at the silos, right? So your different comorbidities are not just different diagnoses. We look at how does that all play into the condition and how you can talk to your provider with the context of the entirety of it. What access to care do you have? Do you have a long COVID clinic? Do you have, a provider who may not be very well versed, but that is willing to learn and is willing to meet, in order to get that information? So it is a very comprehensive system. It's an ecosystem, that takes into consideration all of the factors that go into the state that you're in now, and looking for solutions to help you move forward in the process so you can ultimately meet that goal of improving the quality of life. Next slide. All right.
So we wanted to switch over to what is medical coaching and consulting. And people with MECFS or long COVID and other conditions interact with the medical system. They interact with themselves, and many are individual researchers out of necessity. And the ecosystem that exists is around the person, around their household, around work, if that's a part of what's going on or not, and then who is the care team from a formal clinical perspective. In terms of practicing medicine versus medical coaching and consulting, practicing medicine is largely as described. You need a license to diagnose and treat, and you need a medical license to for prescriptions. And there are some physicians can prescribe, and there are other prescribers as well. And so with the medical coaching, what we're really doing is acting as a partner for navigation of the journey related to these chronic conditions. And so a lot of that is it may be how to communicate the information, what testing's been done, and how does that line up with the various known biochemical pathways, and what may interact in the body. Discussions on where the symptoms may all come together to share a common biochemical pathway. A lot of these, the root issues are sympathetic overload or balance in the neurosystem, speed of processing, which can be related to how the nerves propagate and move information, whether they're inflamed or not. The inflammation, the immune system is a huge part of it. The blood flow and available oxygen, as well as the cycle of energy, the glucose and the metabolism, and so on and so on. Those are all part of it. And we're really talking about the goal is to say, here is this coaching process, and we'll be a partner for that, and to give continuity, to give and work as a partner for coordination. And we have the various members of the team you see here on the call, as well as that will be growing over time. And we, in our twinkle in our eye is people gain more and more expertise in their own conditions, that there may be places where they want to be guides for others as well. And that kind of a self-evolving and growing ecosystem has been worked really well in other parts of the medical community. So we won't be writing you a prescription and say, take this. We might be saying, hey, people with this evidence of biochemical activity have tried, here's what the literature says on a study of, this medicine or that medicine or this supplement or that supplement or intervention, and what that will do based on what's known from a science perspective. And then it might be, gosh, if I do that, what are the complications that might go with it? And so then here would be known complications and things. What are the trade-offs? But the idea is to have a partner in the journey, and a combination of the experience of the journey and the science and biochemistry of the underlying conditions. So largely the scope of practice here is education. It's around the disease processes. How do you, a person might have some GI symptoms, and they might have skin symptoms, and they might have thinking systems and fatigue. And how do those all interact and intertwine? And are there ways that they come together in a common fashion? And are there things that can be done about them? That's what we're talking about in terms of education. It might be education about how the healthcare system works. Hey, I'm having trouble getting in to see this person or that person, or the insurance, how to work that with the insurance system, and how does it get paid for? Sometimes it can, sometimes it doesn't. What might be alternatives that could be used that would work in the same general direction? Interpretation, there are slews of tests, and does this test say there's reactivation of Lyme or babiosis or CMV or RSV or any number of things? Or is there, what do these labs mean? We're not diagnosing the disease with it, but just talking about what those mean from a biochemical perspective. Communicating with the care team, helping to keep a roster of what are the key items that are your goals and necessary in tracking forward. And we'll have a couple of examples of that in a few minutes. But really, it's the individual person journey, which is a collection of what is the makeup of the body before these things happen, and what has happened, and then what do you do about it, and then the environment in which all that exists. Okay, so largely spoken to this from the perspective of what we're doing, what our approach is. I think the key takeaways, for example, item 5, we draw from the literature as well as personal experience of traversing the healthcare system. It's daunting sometimes to do that. And there's been experience over the last few years within Renegade Research with the Remission Biome Project, and we'll show an example of a client here in a minute. But it ultimately ends up a customized roadmap and saying, what are the steps? What does this all look like based on your unique history and current challenges, as well as the biochemistry and what's known from science. From a rollout perspective, we're doing this in 3 phases. The first phase is now, which is you can think of it as if we were a technical product, this would be the alpha, or the beta, rolling it out to initial users, working with them. This is a one-on-one service. There's a coaching form, interest form, and it'll be a small number of people. So we get our systems and our activities right. So we don't have a bunch of chaos, frankly. And then phase 2, we're going to use that as learning how to scale. And we've learned that some from what others have done, as well as the remission biome. And then roll that out to try and have a more accessible, scalable program in October. And then how do you take that and leverage it even further with technology and various interactivities that are becoming more and more straightforward, as long as there are guardrails on it. So we're all asking questions to these AI and large language models. You've got to make sure the answer you're getting back is what you think you're getting back. And there are some ways to do that. And we think we can work to roll something out over the next few months to really, really scale this. And
I'll add here, John, because
yeah,
there was
sure.
a question in the chat too about financial accessibility, is that one of the things since the very beginning that has been really important to us is to not have offerings that are only accessible to a limited number of people, right? And we've done that in various ways through fundraising and grants, and being able to give financial assistance to those who need it. And one of the things in the interest form that we asked for this, very small group of clients that will be accepting first, is that for those who can, if they can offer full or partial scholarships, so we can, from the very beginning, knowing that it is going to be inaccessible to some from a price perspective, we can also include those people without having to wait. And then, as John says, the evolution of the process, and we have some really, really great plans here to scale it to everybody through the use of technology, through group coaching, through increasing the team to have more people to be able to serve, but also here at the end we are developing simultaneously an educational training platform for clinicians, because as much as we're just one group, and we want to equip clinicians to be able to be partners in care with you.
And then in terms of the overall severity and what we're talking about, as we know, these conditions vary by initial presentation and then vary over time. And early on in a condition, COVID there's more of an example of it because there were nailed down timelines in broad groups. But within the first few months, there's a lot of inflammatory activity going on, and trying to quiet those fires before scarring occurs, before fibrosis occurs, before metabolic changes occur. Maybe and while there still may be some residual infectious material around, that makes a bunch of sense from stopping the problem before it starts perspective, or as it's just getting going. As time goes on and you end up with metabolic changes or sympathetic overload, and you get into more moderate, that might be a 6-month or longer with the condition, and it could be even longer than that. And frankly, somebody can be moderate on day 2 also, because they may have a severe disease load or started with having diabetes for 20 years or something ahead of time where there's a predisposing condition that puts them in a rougher place straight away. But the idea is that we're going to focus on the stage and then importantly also what's been tried already. And so if somebody's in the past talking to people, somebody might have had a bunch of things anti-inflammatory and for whatever reason didn't do antihistamines, and antihistamines all of a sudden helped a lot. In other cases, maybe not, but there are just methodically walking through what might help. And then as this gets severe, as some on the call may be in that situation, and certainly out there are lots, that people end up being housebound or even bedbound, where any energy is beyond just breathing and living is challenging. And how do you work from there, which is people have to piece together how does that happen in terms of caregiving and life in general. And we'll try to work in those as well. So we're really talking about the whole gamut, but the idea will be to make a personalized roadmap for each person. And I'm going to turn over to Kat. She's going to talk about some specific examples from some of our current activities.
All right. So as we all know, right, we often get back our initial labs and everything is supposedly normal. Of course, a good doctor is going to look at these things holistically. But if your doctor is strapped for time or you don't have access to a GP where you see the same person regularly, or sometimes they're just not familiar with, they may not look at that whole picture when everything comes back green. It's just green. And as a very basic example, ferritin, which is one of the markers of your iron stores, so not necessarily what is active, but what is available, is something that is sometimes, but not always tested. And it doesn't get flagged as low until it's nearly hospitalizable. So some of the general recommendations for iron therapy, iron replacement, whether that is supplement or otherwise, a ferritin level of less than 75 micrograms per liter, right? Okay, well, what does that mean? As a comparison, Quest marks ferritin as low, as needing supplementation, needing some sort of action at 16. Obviously, by the time we get to there is already so much more damage done, right? At that level, that is, somebody that is going to need immediate medical care or is already developing anemia, right? Whereas you can have iron deficiency without anemia, and that is a common driver of a lot of symptoms that we deal with, like muscle weakness, tachycardia, shortness of breath. And then, unfortunately, typical supplements, poorly tolerated, so we can review some options there. All right, next slide. There we go. So this is just an example as far as ferritin. Results came back. Patient's like, I think my iron's normal. We look at it holistically, look at the whole pattern, look at the ranges. Like, this doesn't look normal. Doctor confirms this is iron deficiency, not yet anemia. Patient begins liposomal iron. So this is a different form of iron that's slightly better tolerated with vitamin C. They had a history of cramping, but by the third day of supplementation, it's gone. Right. So again, a good doctor is going to look holistically. But if you don't have that sort of access for whatever reason, we can help you bring these things to attention so that you can go over them and hopefully get these solutions. And next slide. All right. And then this, of course, is my wheelhouse. So generally, anybody who comes in for coaching, when we're talking about genetics, you're probably going to be talking to me. We have a couple of basic reports that we can run that are very, very fast. But then we also try to go through in a little more detail to try to catch the things that aren't immediately flagged. Genetic testing is more valuable for some people than others. Some people, it may not be the first step they take. It may not even be a step they take at all. But there are certain symptom clusters that really suggest a genetic underpinning, and we can flag those so you can decide what to go for. Usually a cheaper test, totally fine. That'll get you enough information to work with. Testing through our medical system, typically you get tests for one variant at 1 or 2 genes, very slow. Often you need a referral, and often the interpretation is vague or contradictory. So this is one of the things where going to a private test, like an ancestry test or something like that, can speed up the process. Once you know the variants, you can take that information to your doctor. Sometimes you require confirmation testing. Sometimes you can go directly to treatment, right? So nutrients, hormones, medication metabolism, all of these are things do have a heavy genetic component. And once we know those variants, we can help you to customize those common interventions. In addition, inborn errors of metabolism, which just means things where, we have a genetic feature of our metabolism that is already kind of not working right before we get sick, are incredibly common, especially on the more severe end. Obviously, there are a few that are going to be automatically flagged by any testing system you go through, but we've also collected a number of variants that just have unusual frequency in our population, and those are worth exploring. Several of them have turned out to be pathogenic, but the good news there is most of these have really easy treatments that can then reduce our symptom burden. All right, let's continue on.
Yeah, just before we go on, in the news, we saw that the ended up, he passed this week, and it was on the online social media that he was one of the first about 200 people with genetic testing, because people were wondering how somebody could drink a couple of jugs of vodka every night and rock for 3 hours. And it turns out that he had some variants that help to move fats and constituents in and out of cells, and some of those were related to where the alcohol breakdown occurs. And frankly, in some of those, the alcohol dehydrogenase is something that may be very involved in what we're talking about here.
Very.
So it's not even that far away from what we're talking about, but he was made a little differently.
Next slide. All right, so we're going to go into just one case and just give you an example of, what this looks like. This is a young female with long COVID and Renegade 50 participants. October 2023, she was housebound and mostly bedbound and on an extended leave from her job. She has made remarkable progress, even though she hasn't even completed the protocol yet. So we have coached, with her labs, nutrition, the science, supplementation, what options to discuss with her PCP, how to, carry out additional testing, and also how to test using her expanded energy envelope every time it does expand, right? So some of the resources that she has available, because again, we want to make sure that we characterize that not everybody has the same access to the same resources that facilitate, moving forward. So she was able to move in with her parents and have her food prepared, and, had access to being able to get supplements and, doctors who would work with her in terms of prescriptions and whatnot. But 6 months in, she started participating more in house activities and doing more activities of daily living. So instead of having to have her food brought up to her room, she would, be able to go downstairs and eat with her parents, and eventually be able to help in the preparation of a meal or setting the table. And then about 10 months in, she was able to start taking walks outside and started socializing, going to cafes. And about a year in, traveled by herself to her own apartment in a different country, and managed, social activities after that travel. And today she is back in her own apartment. She is in a relationship, has more regular, although still paced social activities. can travel periodically, and is in a stepped return to work. So she'll be starting, working this many hours for this many weeks, and then increasing, testing, what the current capability is to return to work and still maintain, the other social activities as well. And as we continue to work together, the goal is to continue to increase that energy envelope and to be able to help people not just manage the current state, right, but to understand like what to do when you get another infection, right? Have the conversation with your provider ahead of time, so you may be able to get a necessary prescription, and how to pace yourself during that time. What things do you need to have in place at work now that you're returning, so if you do have a downslide, those what do you call it, accommodations are put in place, and so forth and so on. So it's a holistic picture. It's an entire ecosystem of the person and the condition and their environment that we're able to work into how we move forward with this coaching. Next slide, please.
Yeah, and we think that in this example there was some activity and progress at 3 or 6 months, and then another 3 or 6 months after that, and that we're seeing that, and I think others are too, as cycle time. And if you think about when a broken leg heals, it takes 6 to 12 weeks to heal a broken leg, and it's just the amount of time for the body to break stuff down, build up new vessels, lay down the material, and start the remodeling process. And if that may well be going on across the body. So seeing things in not minute to minute, but very often days and weeks is what we're expecting. Places where you'll end up with switches that can occur in metabolism. And these have been seen in some of the remission events where the activity, the sort of raw material is put in place, and then all of a sudden an event changes. Somebody wakes up and are at a different place of clarity. And that has to be related to nerves and speed of processing, just the way the body goes. And so we're working on both of those time dimensions.
All right, next slide. All right, so John alluded to this already. The personalized approach is critical based on needs, access, and whatever resources are available to the person. This condition, it has a lot of heterogeneity, and that's even translate not within this condition, but within the person in itself, as things present differently at different time. There are patterns there, though, and there are things that can be, gleaned. The access to resources makes a difference, and there are layers of dysfunction and feedback loop in the body and the environment that, not necessarily follow the standard patterns. Everything is an input, and there is no such thing as, this doesn't matter, because everything goes into the entirety of the picture. So that collective knowledge of the community, of patients, clinicians, researchers, and those who fulfill multiple of those roles is what is available to guide this process. Based on individual experiences, we can glean knowledge for the path forward from lived expertise, from the conditions and the scientific data. Next slide, please. Okay, so next steps. If you're interested in being in the coaching program at any of the stages, please fill out the interest form, and a link is going to go out in the chat. We will be accepting mostly on a first come basis. That's going to vary a little bit based on capacity, right? So we're taking 10 participants right now, and decisions will go out by Monday. But obviously, you know, we can't take 10 participants that are at the maximum level of need at, you know, at the same time. But we will be, you know, opening up spots on a weekly to weekly basis, and then with additional resources. So, and the form is going to go in the link. I think Rachel has put it in there already. So if you have any questions, if you can, are we still sharing screen?
Yeah, I think I just jumped onto something. I'm trying to get it to break out. Sorry.
Oh, that's okay. If you can stop sharing.
Oh,
So the email is coaching@renegade-research.org, and you can send, you know, additional questions there. A question in the chat is if we can comment on how this coaching matches with the remission biome protocol, and are we open to all ages of coaching? So as far as matching with the protocol, this is not protocol specific, right? Again, that goes to the individuality. We have learned so much in the protocol, and one of the biggest lessons has been how individual, you know, everyone is, right? So while, you know, talking about the protocol and maybe looking at that as a framework for a person, maybe, you know, the way to go with a particular individual, that's not the goal with everybody. And then as far as children, it's not where our expertise is. So we had discussed that you know, maybe ages 16, 17, as long as it is the parent, you know, guiding all of the interaction and so forth, would be somewhere we could, you know, we could go if there's a need. But any younger than that, it's you know, it's definitely out of our wheelhouse. All right, so I think we have a couple of questions. The logistics of coaching, number, frequency of sessions, etc. So we are starting with a 3-month program, and then the people who enroll and are accepted will have the option to renew on a 6-week basis. And within that, we have 3 appointments that are 1 hour long, one that is 2 hour, and 2 30 minutes. So there'll be follow-up throughout those one-on-ones. There's going to be email communication. There's going to be reports. So it'll be a very close interaction with the participants for those 90 days. And then again, the next stage for October is what we're hoping to do is take, you know, people who have very similar presentation, and we can offer more of a group setting, you know, maybe 1 or 2 one-on-ones within that 90-day period, but more of a group coaching. And then we're looking at technology that would allow us to deploy this at a much larger scale in January. So, and that is it for the questions. Thank you very much, everybody. This will be posted later today. And
there's a request to repeat the hours of one-on-one coaching over the 3 months in the question, just came up.
I will post them with the recording so everybody can have access to it. All right. Thank you, everyone. Have a great day. Bye-bye.